University. I'm a co-founder and the president of the Eastern Mediterranean Oncology Group, EMOG. Really, I'm honored to have all this great faculty in this meeting. Let me start with a short presentation and introduction to this meeting, please. This is our EMOG first Immuno-Oncology Symposium, and it is our seventh virtual meeting that organized by our group. Our group actually is based on an NGO society, which is under establishment in Cairo, Egypt, and it includes faculty from Egypt and the Gulf region, and hopefully it will be bigger and bigger by time. We thought about the Immuno-Oncology Symposium because one of our great successes the last year is the great responses and survival benefit we get with the immuno-oncology to our patient. Like a case like this, this is a case of HCC with metastasis in the porta hepatis lymph node. Actually, the patient underwent resection of the primary lesion 5 years ago and then developed the porta hepatis lymph node metastasis. And after 3 cycles only of combination of targeted therapy and immuno medication, she got a complete metabolic regression and almost 90% morphological reduction in the porta hepatis lymph node on the left side before the treatment. And this is the image just after 3 cycles of the treatment. We have a great faculty, alhamdulillah, in this meeting. We have Dr. Joaquin Belmont, who is the director of bladder cancer program at Beth Israel Deaconess Medical Center, associate professor of medicine at Harvard Medical School. Dr. Tahir Tuwijiri, he's a consultant oncology, medical oncology section, College of Medicine, Al Faisal University, King Faisal Specialized Hospital and Research Center in Riyadh, KSA. Our great professor, Dr. Shawqi Bazarbashi, is adjunct professor, College of Medicine, Al Faisal University, director of Oncology Center at King Faisal Specialized Hospital and Research Center in Riyadh, KSA. We have my friend and my senior, Dr. Muhammad Yassin. He's an assistant professor of clinical oncology at Ain Shams University. Dr. Ahmed Hassan, a consultant oncology at Ain Shams University, and he's a visiting consultant of oncology at NHS UK. Dr. Muhammad Ashur, our colleague from Al-Azhar University. He's a consultant oncology at Kuwait Cancer Control Center now. Dr. Maya Azzuddin, assistant professor of clinical oncology at Ain Shams University. My friend, my colleague, and my brother, Dr. Ahmed Badran. He's an assistant professor of clinical oncology at Ain Shams University, and he is an associate consultant at King Faisal Specialized Hospital and Research Center. Dr. Ahmed Saeed, he's a consultant clinical oncology and director of thoracic and genitourinary malignancy at Ain Shams University. Dr. Muhammad Kilani, assistant professor of clinical oncology at Ain Shams University. And my colleagues and co-founders of the EMOG group, Dr. Ahmed Ali, he is a consultant clinical oncology at Zagazig University and the IMC International Medical Center in Egypt. And Dr. Ahmed Abdelhadi is a lecturer of clinical oncology in Mansoura University. And I'd like to thank also our partner and sponsor for this event, Bristol Myers Squibb, for their generous sponsorship for this event. And their guest speakers, Dr. Amr Shafiq, Assistant Professor of Clinical Oncology at Shams University, and my colleague and friend, Dr. Nawal Tuhami, Consultant Medical Oncology, Electricity Hospital, Egypt. And I'd like to thank the organizing partner, Worldwide Academy for Event Organizer, and Mr. Sameh. And let me also announce about our, inshallah, next meeting, which will be in the 8th of April. It is about prostate cancer. It will be Prostate Cancer Day. It will be in the 8th of April from 6 to 10 p.m. Cairo local time, or from 4 to 8 UTC time. Thank you, and I hope you enjoy this meeting, inshallah, over 2 days. And let me introduce our great first speaker, Dr. Ahmed Ali Badran. Dr. Ahmed Ali Badran is an associate professor of clinical oncology at Ain Shams University. He is currently joining medical oncology section at King Faisal Specialized Hospital, Riyadh, Saudi Arabia, and he is a fellow of European College of School of Oncology and member of European Society of Medical Oncology and American Society of Clinical Oncology. Dr. Ahmed will give us a talk today about unleash of the tumor microenvironment, insight from tumor microenvironment. Dr. Ahmed, please, you have the microphone. Dr. Ahmed, please unmute the mic, please.
Bismillah ar-Rahman ar-Rahim. Thank you, my brother, Dr. Ahmed Kavalla, and thank you for having me today among these great panelists. And it's an honor for me to start the introductory lecture for this event. My presentation will be subdivided into 4 subtypes. I will tackle the tumor microenvironment quickly, trying to understand the mechanism of action of immune therapy in general. Then I will discuss types of immune therapy in the second part. I will go quickly through the biomarkers and the predictive of response. Then I will end up by the future perspective of immune therapy. To understand the tumor microenvironment, we had to know that tumor microenvironment is centered with the neoplastic mass, with the neovasculars in between. Then we have the surrounding mesh of interacting cells. There is a lot of cells. Most of them are inflammatory cells, has either an inhibitory or stimulatory role. This mesh is not respecting the normal histological architecture we know, because the tumor, once infiltrated outside, it starts to produce a lot of cytokines and chemokines and growth factors like platelet-derived growth factors, which induce proliferation of the collagen and fibroblasts, making the tumor unorganized mass of angiogenetic vessels and collagen and matrix. This tumor microenvironment, if we had a deep look, it's consistent of tumor cells in a mesh of collagen and filtrated by fibroblasts, and a lot of inflammatory cells infiltrating this mass. These inflammatory cells, either T cells or B cells, eosinophils, mast cells, and among those T cells, we have different subtypes. We have regulatory cells, or CD4 plus T regulatory cells. We have the cytotoxic CD8 positive cells. This effector cytotoxic CD8 cells has stimulatory effect, which induce tumor immune cell cycle, as I will come to it shortly. And the T regulatory CD4 positive cells is at inhibitory cells, and their components or percentage inside this tumor microenvironment may help us predict the response later on for the immune therapy. So we ended up by an onion-like shape, or that the tumor itself is insulate themselves from the natural immunity by layers of immunosuppressive by the dense layers of immunosuppressive stroma. So the immunotherapy works here by peeling back these layers of local immunosuppression, so restoring the capacity of the natural immune system to eradicate the tumor cells. How it happens? The mechanism is by we have the tumor itself start to release antigens. These antigens picked up by the antigen-presenting cells or dendritic cells through 2 parts, major histocompatibility complex 1 and the major histocompatibility complex 2. This priming process happened in the lymph node by activating these cells. These activated T cells are trafficking through the blood vessels again to the tumor, where it induces tumor effect and killing effect, and by which a new antigens happens and the cycle keeps go on and on. So as I mentioned, this tumor or cancer immunity cycles is happened in different sites or different anatomical locations. The priming is in lymph nodes, and the activating T cells comes out from lymph nodes through the blood vessels, infiltrating the tumor, and this infiltration is subjected to either inhibitory or suppressor signals and stimulatory signals. The immune itself is a complex system. It is composed of multi anti-cancer mechanisms, either through the antibodies released by B cell or T cell mediated, either specific or non-specific. Non-specific, as we all know, by natural killer cells, specific or adaptive immunity through the CD8 positive cytotoxic T cells, and induced, stimulated or inhibited by CD4 cells. The tumor is inducing some inhibitory effect on these regulatory mechanisms that make it evade or escape from the immune effect. How it happens? This is the famous 3 E's of immune editing process. Through the immune editing process, we have 3 phases. The elimination phase, by which the tumor starts to release the antigens, which is picked up by the immune system, by the dendritic cells. Then we have an equilibrium phase, where equilibrium happens between the killing effect of the immune cells and the tumor. Then we have the escape. Because of this escape phenomena or escape phase, we have the metastasis and we have the tumor proliferation we face in our patients. So let's have a deeper look on the T cell. T cells have a lot of receptors that helps it process her adaptive response to the tumor. These receptors either subjected or exposed to activated stimulatory signals or inhibitory signals, like which in the PD-1, PD-L1 signal or B7-1. So by controlling these signals that control the adaptive T cell response, we can have the function or the mechanism of action of the immune therapy. The immune therapy either working in periphery, as we have in the CTLA-4 scenario, or in the tumor microenvironment, as in PD-1, PD-L1. I will show you how. We have here the major interaction is between the major histocompatibility complex and the T cell receptor. For this interaction to happen for the priming in the lymph node, there is an interaction which is stimulatory actually between a receptor is CD828 and B7. If this interaction happens, a cascade induced in the T cell that end up by release of CTLA-4. The CTLA-4 is in competitive inhibition with CD28 on B7, but CTLA-4 is an inhibitory protein. So ipilimumab or the anti-CTLA-4 drugs in general works by removing this brake. So keeping the T cell in continuous priming and stimulation and activation. In the tumor microenvironment, we have different mechanisms. We have the PD-1, PD-L1 expression or interaction. The PD-L1 is expressed on the tumor. Actually, it is not expressed in the tumor only, it is expressed in all human tissues, but overexpressed in tumor cells. It's for the major for the direct killing effect of the T cell on the tumor itself to happen. The interaction shouldn't be there because it is inhibitory interaction. Or inhibitory signal induced if the PD-L1 from the tumor interact with the PD-1 from the T cell. So the anti-PD-1, PD-L1 working by blocking this interaction. The evolution of immune therapy is long-standing from the past, and we all know the history of the first immune therapy used, the BCG vaccine. Then it passed through many phases. Because of the time we will not discuss in details, ended up currently with the anti-CTLA-4 and PD-1, anti-PD-1, PD-L1, and we have the future perspective of the biphasic antibodies. I will discuss this. Now, the immune therapy is forming the backbone in treating many cancer sites, either as a monotherapy or in combination with chemotherapy, radiotherapy, and surgery. And the long list of approved medications from FDA is getting longer and longer day by day. Now I will discuss the types of immunotherapy shortly. We have 4 subtypes of immune therapy. We have the immune checkpoint inhibitors, as I discussed the mechanism shortly a while ago. We have the vaccines. We have the T-cell adoptive transfer, and we have the drug conjugate, antibody cytotoxic drug conjugate. The vaccines are subdivided into preventive vaccines as a scenario of human papillomavirus and hepatitis B virus. And we have therapeutic vaccines, and it is an area of active research currently, although still the results didn't show impressive results or response. Then coming the CAR T cell, or the adoptive transfer of T cells targeting the cancer neoantigens. The idea of the CAR T cells that we pick up a part of the tumor, culture it in an interferon gamma and interleukin media, activated the T cells that attack the tumor cells. Once these tumor cells finished, this activated T cells is collected, and we have part of the tumor that had been processed and engineered ex vivo and presented on a chimeric antigen to these activated T cells. So these activated T cells is transfused back again to the patient, and it should promise, especially in heme-onc. I explained already the immune checkpoint inhibitor mechanism. This is not for free. It is with a cost. The cost is, I captured this picture from New England Journal of Medicine. The cost is that the immune therapy has adverse effect in each part of the body. It is in form of auto-inflammation up to an autoimmune-like picture or itis. It can affect, as I mentioned, any part or any organ. And there is also some mild infection, some mild side effects like fatigue, fever, and infusional reactions. Better biomarkers lead to better therapy. So it enables the right therapy to the right patient. What are the biomarkers suggested for immune therapy? This is an active area of research. To understand what are the biomarkers of response to immune therapy, we had to have knowledge about what affects the tumor microenvironment, or we can name what are the tumor microenvironment modifiers. We have here 2 subtypes of tumor microenvironment modifiers. We have direct modifier acting on the tumor itself, like the chemotherapy, radiotherapy. We have indirect modifiers. Indirect modifiers is heterogeneous group, can be divided into host factors or tumor-related factors. The tumor-related factors, the first of which that was studied extensively is the PD-L1 expression, tumor mutation burden, microsatellite instability high, or status in general, tumor infiltration lymphocytes, interferon gamma, and cytokines and chemokines in this complex mesh, and gene signature. The PD-L1 expression is a non-reliable marker, and if we go through the clinical studies with our respected speakers in the upcoming lectures, we will find it is not suggested at all as a predictive of response. Why is this? The PD-L1 expression is in all human tissue, as I mentioned, but sometimes overexpressed in tumor tissue. We have here tumor cells is expressed by PD-L1. We have the immune cells expressed by PD-L1, and we have this resolved in 2 scores. The tumor positive score, which is the ratio of the viable tumor cells stained by PD-L1 to the viable tumor cells, or the combined positive scores, which add the viable tumor cells stained plus the lymphocytes stained in ratio to the viable tumor cells. The gene expression itself of the PD-L1 is not present except in 0.7% of the solid tumors, although it can be presented highly in Hodgkin lymphoma. While what we see is just somatic mutations in the tumor, not genetic expression. Next is the tumor infiltration lymphocyte. The tumor infiltration lymphocyte.
Time, please.
quickly, tumor infiltration lymphocyte depends on the ratio between CD8 and CT-reg, and we can divide the tumors to hot tumors and cold tumors according to the presence of the CD8 cytotoxic in compared to the CD-reg, and it affects the survival endpoints in many trials. We have the tumor mutation burden, and in some trials we'll find that smokers behave better than non-smokers because of high tumor mutation burden. High tumor mutation burden works by altering the end result amino acid, which induce more immunogenicity that cause more recruitment of immune cells. Microsatellite instability in many trials now is a surrogate marker for response to immune therapy. Quickly, we have biomarkers related to the host. We have gut microbiota. We have blood biomarkers like neutrophils lymphocyte ratio. We have myeloid-derived suppressor cells. We have lactate dehydrogenase. All these are in active research now, and also in consequence with the circulating liquid tumor cells and liquid biopsy, how we can detect them by liquid biopsy. Tumor microbiome, changing the media around the tumor, and many studies now showing that in certain microorganisms there is a favor response to immune therapy, and some studies showed the inverse proportion of survival while we use the antibiotics with the immune therapy. I'm sorry of being quickly, but I would like to catch my time. So my last part in the presentation is the future perspective. This picture or this bullseye card extracted from Nature Science, which suggests the possible targets for the next generations of immune therapy, and it depends in the center here on if this tumor is hot or highly immunogenic. We will go for stimulatory components, or intermediate or cold, we will go to inhibit the inhibitory factors. And now we have the combination of immunotherapy with chemotherapy or chemoradiotherapy. We all know the abscopal effect with radiotherapy. We have the IO by two different mechanisms, like BDL1 and CTLA4 in melanoma or RCC. We have the combination with the anti-other targets like BRAF and MEK, or anti-VEGF like RCC and HCC. Next generation immune checkpoints are with other targets. We have now targets to LAG3 or TIGIT or TIM3. We have the bispecific antibodies by combining two targets in the same antibody and other factors targeting the tumor microorganism. Quickly, I will highlight what is LAG3. That is have a promising role in melanoma currently. LAG3 is an inhibitory protein released in the exhausted T cells. And the anti-LAG3, like relatinib, is working by blocking this protein. So it re-induces a stimulatory effect on the T cells and giving a boost to the immune system against the tumor. I conclude by combination immunotherapy is the future of cancer therapy. The T cell inflamed tumor microenvironment is a good biological guide to IO drug development. Many novel IO approaches being developed, of which is anti-LAG3 and TIGIT, and also the biphasic antibodies. Thank you.
Thank you, Dr. Ahmed, for this nice, comprehensive presentation. I know it is difficult to present this hot topic in 15 minutes. Now we have, I think, a couple of minutes for any question from the audience. So anyone need to ask Dr. Ahmed about any question, just send in the Q&A and we will answer shortly. Okay, I think we didn't receive any questions till now, so I will shift for the next speaker. Thank you, Dr. Ahmed, for this presentation. And we have, if we have for you after the next speaker, I will tell you, inshallah. Our next
speaker,
I
will be available.
Thank you, Dr. Ahmed. Our next speaker, inshallah, Dr. Shawi Bazarbashi. Dr. Shawi Bazarbashi is adjunct professor of at College of Medicine, Al Faisal University. He is the director of Oncology Center at King Faisal Specialized Hospital and Research Center in Riyadh, KSA. Dr. Shawi will present for us today IO in GI malignancy, A New Hope. Dr. Shawi, please.
Sorry for the delay. Just tell me if you can see my slide well. Can you see it?
Yes, perfectly, Doctor.
Yes, Doctor, we can see.
Thank you very much. And thank you, Dr. Ahmed. And thanks for the organizers to let me join this distinguished group. So I'm not sure if it's 15 or 20 minutes. I'll try to finish as soon as possible. It's a big topic. I was asked to
it's 20 minutes, Dr. Shawi, 20 minutes, inshallah.
Immuno-oncology or immunotherapy in GI malignancies, a new hope. And to start with, let me see. So sometimes it takes just 1 or 2, 10 or 20 seconds to move, which is typical, but that's fine. It will move. So to start with, let me just talk about what are the predictors of response to immunotherapy. And Dr. Ahmed Badran has actually discussed this earlier. And as you could see, we have a mutational load. We have what we call hot versus cold tumors. We have the microsatellite stability. We have the PD-L1 status. Also, we have other factors. You all have seen this very well cited slide that actually shows you the mutation frequency in different cancers. I've highlighted to you the GI cancers with the stomach, esophagus, and colorectal being one of the frequent one that has high mutation burden. In general, not the highest, but somewhat high. Pancreas, as you could see, is in the midway, so does not have that much of mutation burden load. Now, when you look at the mutation load and the MSI, they're probably two different faces for one coin. So you could see here in this study, for example, the authors have looked at in patients who have macrosatellite instability versus those who have macrosatellite stability. So you have here on the left side up, you have the sample size of 28 patients with the macrosatellite deficient colon cancer, where there is 50 mutation per 10 megabase. And while the ones who are stable, there are 6. Similarly, in another gene panel, you have those who are macrosatellite unstable has a higher mutational load than those who have stable. So it's actually very much interrelated thing. Now, when we look at immunotherapy in GI cancer, there are probably immunotherapy is approved in only 2 GI cancer, esophagus and stomach, if we can consider them one organ, and the colorectal cancer. We have little encouraging data in pancreas, some encouraging data in the biliary tree, and very minimal data in the anal canal. And I was asked not to talk about hepatocellular carcinoma because that will be presented at a later stage. So in colorectal cancer, there are 3 approvals for immunotherapy. Pembrolizumab initially was approved in the 3rd line setting. Nivolumab was approved in the 3rd line setting, and the combination of Nivo and ipilimumab were approved in the 3rd line setting. However, Pimpro recently was approved, as I'll discuss with you at a later time, in the 1st line setting in patients who are MSI high, and all those approvals are in MSI high. The first publication about the response of MSI high colorectal tumors as compared to those who are MSI stable came and published in the New England Journal of Medicine in 2016 or 15, and showed that the response rate, though with a very small numbers, only 10 patients, in patients who are MSI high, was 40% compared to 0% in patients who have macrosatellite stable. So that was the first triggering study that led people to go and do more studies. And the one that came after was the Keynote 164, which actually had two cohorts. Cohort A who had more than 2 lines of therapy, cohort B, colorectal cancer, who had only more than 1 line. So if you look, actually, you would see that that bottom of the slide, in the cohort A, only 10% had 1 line. In the cohort B, about 40% had 1 line. So it's more earlier cohort. What you see here, response rate is equal in both cohorts for pembrolizumab, but what you see here is doubling of the progression-free survival in the cohort B, which has more patients receiving only 1 line of therapy as compared to the cohort A with the PFS of 2.3 months, and also a higher overall survival being not reached in cohort B, but 31 months in cohort A. Now, based on this, that was the needs for the Keynote 177 trial that took patients with MSI high tumors and randomized them to the standard of care, which is either FOLFOX or FOLFIRI chemotherapy, plus either bevacizumab or cetuximab, according to the RAS status, versus the investigational arm, which was pembrolizumab. And in this trial, they allowed for a crossover, and the primary endpoint was PFS in the intention to treat by independent review committee. So there was no selection for PD-L1 status, and there's no question that the trial met the primary endpoint, with the PFS being doubled from 8.6 to 16.5 months. And many people always talk about the first part of this graph, with the chemotherapy having slightly better PFS. But let me just remind you, if I can move this slide. It happens always. It stops some. I think it wants to relax. So what I'm going to show you in the next slide is the response rate that is about 10% higher in the pembrolizumab than in the chemotherapy. So about 44% in the pembrolizumab versus 33% or 34% in the chemotherapy, as you could see here. Also, you could see that in the waterfall plot. Not to mention, those who respond from chemotherapy is not the same as those who respond from the pembrolizumab, because of the response with pembrolizumab is much better. Now, the only thing that worries me about this trial is the benefit for those who are KRAS or NRAS mutant, and you see that the benefit goes better for the chemotherapy arm as compared to the pembro arm. How about nivolumab? Nivolumab was tested in a large checkmate 142, multiple arms. I want to show you the data quickly. Nivo alone showed a response rate, showed a PFS of 6.6 months. Those are patients who have received previous chemotherapy, so it's being given as a second line or third line, and the overall survival was not reached. Look at survival for those who achieved CR or PR. At 30 months, none of them has died. All of them are alive. So another checkmate trial, which is a Nivo plus Ipi combination, which we know with a median follow-up of 25 months, both the PFS and the overall survival were not reached, and you could see how good those survival curves are. Though this is not a randomized trial, this is showing you on the left the PFS for Nivo alone versus Nivo plus Ipi, and the Nivo plus Ipi was better in both PFS and in overall survival. The last one about Nivo and Ipi is the one who was done in the first line setting in patients with MSI high, of course, and you could see that both the PFS and overall survival were not reached. So based on this, in colorectal cancer. Pimpro was approved in the first-line setting in the MSI-high metastatic disease, and any of them, Pimpro, Nivo, or the combination of Pimpro, Nivo, were approved in the third-line setting in patients with MSI-high. Now, how about GE junction or gastric, esophageal, and GE junction tumor? And there's quickly 4 trials that I want to show you. The first was the Keynote 062, which had 3 arms. The standard arm was the chemotherapy plus placebo, and 2 investigational arm was pembrolizumab alone or Pimpro plus chemotherapy. Primary endpoint was overall survival and PFS, so it was co-primary endpoint. Now, the first of the primary endpoint was non-inferiority of Pimpro versus chemotherapy, and it met only this primary endpoint, but there are multiple other primary endpoints that were not met, unfortunately. So it was non-inferior, but for example, what we were able to see from this trial is, for example, in patients with CPS more than 10, Pimpro had a much better overall survival of 17 months compared to 10 months, but there was no statistical testing because the trial failed to actually reach the other primary endpoints. Also, they looked at patients with MSI-high, and there is no question, regardless of the CPS score, the patients who have received pembrolizumab in the first-line setting do much better in terms of overall survival, whether the CPS is more than 1 or more than 10%. The second trial is the Checkmate 649, randomized patient. This is a global study, randomized patient to the standard of care, metastatic gastric or gastroesophageal, or even esophageal adenocarcinoma. So they took adenocarcinoma, whether it's from the esophagus or from the stomach or GE junction. And as I said, 3 arms, Zelox or Folfox, which is the standard, Zelox or Folfox plus nivolumab or Nivo-Ipi, and the primary endpoint was a dual combination of overall survival and progression-free survival. Now, the trial was positive, and the primary endpoint was PFS or overall survival in patients with CPS more than 5, and this trial, this primary endpoint was reached, and the survival went up from 11 months to 14.4 months. Now, the second endpoint that was actually positive is in all comers. Let me remind you that those patients were not limited to any PD-L1 in all comers. The third one, the third trial that was actually, I would say, semi-positive is the Attraction 4 trial. And that actually included patients with gastric cancer or GE junction. And those patients were randomized to chemotherapy. And because this is Oriental trial, the chemotherapy was Capox or SOX, S1 plus oxaliplatin, versus chemotherapy plus Nivo. Primary endpoint was a combination of PFS and overall survival. Also, it was unselected. So one of the primary endpoints was actually positive, which is PFS from 8.3 to 10.4. That was statistically significant, but unfortunately, overall survival was not significant. But let me show you that the overall survival in the placebo arm here is 17 months, and remind you that in all other trials, our chemotherapy alone give us about 9 to 10 months of overall survival. And the reason is by, if you look at the Attraction 4, the lowest row, you see the second line immunotherapy was given in 27% of those patients, as compared to, for example, 15% in the Keynote or in 8% in the Checkmate. The Keynote 590 is an esophageal trial, looked at both squamous and adenocarcinoma of the esophagus, and randomized patient in the first-line setting to chemotherapy plus placebo versus chemotherapy plus pembrolizumab, with the primary endpoint being a combination of overall survival and PFS, very complicated hierarchical statistical analysis. This was a positive trial. The adding Pimpro to chemo improved overall survival in those with the CPS more than 10, squamous cell carcinoma, in unselected squamous cell carcinoma, in squamous or adeno with a CPS more than 10, and even in all patients, squamous and adeno unselected, but the hazard ratio was slightly lower, being 0.73. Now, how about second line in stomach and esophagus? The keynote 61, this is a negative trial looking at second line in the stomach, randomizing patients who failed first-line therapy to Pimpro versus paclitaxel, and this trial was restricted to patients with CPS more than 1%. The trial was negative. There was no improvement in overall survival. The Attraction 3 trial was an esophageal trial that looked at only patients with squamous cell carcinoma and randomizing patients in the second line for nivolumab versus docetaxel or paclitaxel. Primary endpoint was overall survival, and the trial was positive with an improvement in overall survival. The third trial was also an esophageal trial, Keynote 181. However, it looks not only squamous cell, but squamous and adeno, and also randomized patient for either Pimpro or for paclitaxel or docetaxel or irinotecan. And it has multiple primary endpoints, and the trial was positive in patients with CPS more than 10%, regardless of the histology, or if they had squamous cell carcinoma, but not in unselected population. In the third line setting, you have the Keynote 059, which is a phase 2 trial in gastric cancer that showed that based on this, Pimpro was approved by the FDA in the third line setting based on overall response rate of 11%. And in those third line, as you could see on the right side, with PD-L1 positive, 22% response rate, and an overall survival of 5.6 months and PFS of 2 months. Now, the Attraction 2 trial was approved only in Japan. Patients in the third line setting were randomized to either placebo with best supportive care or nivolumab. Primary endpoint was overall survival, and that was positive. There was an improvement in the overall survival. Of course, the Javelin in the third line with avelumab was negative. Adjuvant immunotherapy was tested only in the esophagus, patient who received pre-op concurrent chemoradiation followed by surgery. Those patients who had residual disease after surgery were randomized to either nivolumab or placebo, with the primary endpoint being PFS. This trial was positive with an improvement in PFS, doubling of the PFS. We are waiting for the overall survival. So just quickly, how do I manage gastroesophageal cancers? Regardless of the location, adenocarcinoma, if it's in the esophagus or GE junction, preoperative chemoradiation, residual disease, they receive adjuvant nivo. If it's adenocarcinoma, esophagus or stomach, no prior chemotherapy. First line, if they're CPS more than 5, they receive chemo plus nivo. And in the second line, there is no role for immunotherapy. In the third line, nivolumab is based on level 1 evidence. If you have squamous cell carcinoma of the esophagus, similarly, chemoradiation followed by resection. If there's residual disease, adjuvant nivolumab. Metastatic disease, first line metastatic, you give chemo plus pembrolizumab. Second line, if they have not received immunotherapy, nivo or Pimpro. And third line, there is no role for chemotherapy. I think my time is off. The biliary cancer data is actually interesting, but it's not approved. So I'm going to pass on that and say that efficacy of nivolumab in refractory PD-L1 positive there is efficacy, but it's not approved. And I here stop, and I'll be willing to answer any question. Thank you for listening.
Thank you, Dr. Shawi, for this comprehensive lecture. Actually, I learned a lot from this. Now I ask the attendees if they have any question we would like to answer. I think we received one question, but I think this is for Dr. Badran. But Dr. Shawi, if you want to answer, it is okay. He's asking, pembrolizumab is a PD-1 inhibitor and showed efficacy in RCC. And Dr. Badran said that the PD-1 expression in RCC is less than 1%. So how this efficacy came out in RCC?
No, I didn't say it is less than 1% in RCC. I mentioned there is two types in solid tumors. Yes, it is heterogeneous marker. We cannot depend on it. We cannot say this RCC we will have a solid definite PD-1 expression. I cannot say melanoma have 60%, RCC have 40%. We cannot say this. We have different types of RCC, and we can have different and variable degrees of the PD-1 expression. It depends, this variation depends on the patient himself, on the body, whether this tumor is expressor of the PD-L1 or not. But if we compare in certain types like Hodgkin, we have genetic alteration of the gene which induce the production of this PD-L1 protein. This genetic variation is happened in certain diseases like Hodgkin disease or Hodgkin lymphoma. That's why we usually face in most of the Hodgkin disease or Hodgkin lymphoma, high PD-1 expression. But in other tumors, we cannot see this. It is very unvariable and heterogeneous biomarker.
Thank you, Dr. Ahmed.
Maybe,
thank you, Dr. Shao. You didn't receive any question. I think usually we are receiving the question in delay. Before shifting for the next speaker, please let me speak in Arabic. احنا لسه سامعين دلوقتي خبر يعني سيء للغاية. أستاذنا الكبير وأخونا الكبير أستاذ دكتور عمرو لطفي أستاذ الأورام في طب عين شمس توفاه الله. فأنا أرجو من كل الناس اللي حاضرين وسامعينا يدعوا الدكتور عمرو بالرحمة والمغفرة. ربنا يرحمه ويغفر له يا رب. And I think we received a question for Dr. Badran, and then I will shift for the next speaker. Dr. Badran, you suggest biopsy to test for PD-1 expression prior immunotherapy in RCC? I think all the data said no.
No, I didn't suggest that. That's why I said it is unreliable marker. When I introduced the PD-L1 expression, I told that it is one of the indirect tumor microenvironment modifiers, but it is unreliable. And initially, it is thought to be a predictor of response. Then the clinical trials later on failed to show that it is correlated with the response. And then most of the studies now are directed regardless the PD-L1 expression.
Yes. Thank you, Dr. Shawi. Thank you, Dr. Badran, for your excellent presentation. Let me introduce now my dear colleague, Dr. Muhammad Yassin. Dr. Muhammad Yassin is an assistant professor at Ain Shams University Clinical Oncology Department. Dr. Muhammad will present for us IO in HCC, first line and beyond. Dr. Muhammad, you have the floor.
Thank you, Professor Dr. Ahmed Gaballah. I would like to thank all the EMOG group for this fruitful scientific meeting, as usual. I will start to share my screen. Okay. اوكي كده ماي سكرين باينه. ها دكتور احمد.
تمام يا فندم شايفينها. اتفضل يا فندم.
My topic today will be IO for hepatocellular carcinoma first line and beyond. These are my disclosures. When we talk about hepatocellular carcinoma, the issue is that we have one patient with two diseases. 80 to 90% of HCC patients have coexisting cirrhosis, which leads to loss of normal architecture and microcirculation, reduced hepatocyte mass and function, reduced regenerative ability, which leads to portal hypertension, reduced liver function, reduced hypertrophic response. So in HCC, we have underlying liver disease and cancer. And liver disease is classified by Child-Pugh score, incorporates laboratory, radiological, and subjective assessment. Cancer is classified by stage, potentially resectable or transplantable, operable by performance status or comorbidity, unresectable disease, inoperable by performance status or comorbidity with local disease only, and metastatic disease. It is very important to know exactly the Child-Pugh liver function score, which includes total bilirubin, albumin, INR, presence of ascites, presence of encephalopathy. Class A is the one that we usually treat. The liver can tolerate treatment and patients tend to be treated aggressively. Class B, the liver is compromised and may not be able to tolerate treatment. And we have only 2 drugs approved in HCC till now, which have been studied in Class B Child-Pugh, sorafenib and nivolumab. Class C, the liver is too damaged to be able to tolerate treatment. So hepatocellular carcinoma current diagnosis and staging, we have very early and intermediate, and all have locoregional therapy as a treatment option with estimated survival time more than 5 years for very early stage and early stage, and for intermediate stage more than 2 years. And in advanced stage, the liver function is also preserved. There is microvascular invasion or extrahepatic spread, and the treatment option is systemic therapy. And the estimated survival time was, before the approval of IO in first line, was 11 to 13 months in first line and 8 to 10 months in second line. While after the approval of Atezo-Biva, according to the EMBRAVE 150 trial, we have reached an overall survival of 19 months. And then drugs which have been used in first line, like sorafenib and lenvatinib, can be moved to second line, and drugs which have been approved in second line to third line. So there is improvement in survival time after the recent approval of IO in first line HCC. And I think this year and next year, there will be more approvals for IO therapies combination in HCC. The terminal stage, best supportive care and estimated survival time is around 3 months. So what is the rationale for immunotherapy in HCC? Chronic liver disease promotes inflammation and carcinogenesis. Liver inflammation may be due to a number of factors. Viral function, alcohol use, and non-alcoholic steatohepatitis contributes to an immunosuppressive tumor microenvironment, increased immune cell infiltrate but ineffective anti-tumor response, expansion of myeloid-derived suppressor cells and Tregs help tumor cells invade immune detection, secretion of immunosuppressive cytokines, TGF-beta and interleukin 10. The liver is tolerogenic, tolerates foreign antigens, increased risk of viral infection, which can lead to chronic liver damage, decreased liver function, increased cirrhosis, increased cancer risk. So HCC may be considered 2 concurrent disease, cancer and liver disease. So PD-1 and CDL4 are immune checkpoints found on T cells. Inhibiting these negative regulators of T cell immune function can reinvigorate T cells and augment anti-tumor activity. Identifying who might benefit from checkpoint inhibitors. Biomarkers are needed. PD-L1 has not generally been shown to be predictive of response to immune checkpoint inhibitors in HCC. There are no data on tumor mutation burden as a predictor for response to immune checkpoint inhibitors in HCC. Etiology of the disease appears to have no effect. Patients with HCC stemming from hepatitis B or C or alcohol or NASH or NAF appear to respond similarly. Sequence may matter, but it's currently unknown. Will prior TKI exposure help modulate the tumor immune microenvironment to prime the immune system? So, till 2017, we had for 10 years the only approved drug in metastatic HCC or advanced HCC, sorafenib, which was the only dogma for around 10 years. And HCC was an orphan disease area until the approval of regorafenib, then lenvatinib, and then accelerated approval for nivo and pembro and nivo-epi in second line, and the approval of ramucirumab according to the REACH2 trial and cabozantinib according to the Celestial trial. So as we see here, what happened in the last 3 years, we have the approval of many drugs in the area of treatment of metastatic HCC. This is the ESMO treatment guidelines for HCC. I will go very fast through it. And this is the NCCN guidelines for HCC. First line now we have sorafenib for Child-Pugh class A or B7, lenvatinib, according to the reflect non-inferiority trial, category 1, atezolizumab, child class A, and useful in certain circumstances, nivo, if ineligible for TKI or other anti-angiogenic agents, which is category 2B, and for FOX, which is approved only in China. Options for the second line, we have regorafenib, cabozantinib, ramucirumab for alpha-fetoprotein more than 400, and we have accelerated approval nivo, nivo-epi, and pembro for child class A, and for nivo class B also can be included. And if we have used atezolizumab in first line, we can move sorafenib and lenvatinib to the second line. So the rationale for immune checkpoint inhibitors combination with anti-VEGF, BEVA is an anti-angiogenic agent with additional immunomodulatory effect. In combination, BEVA may further enhance atezo efficacy by reversing VEGF-mediated immunosuppression to promote T-cell infiltration into the tumor cell. The IMbrave 150 trial was published May 2020 in the New England Journal of Medicine by Professor Richard Finn. And this is the design of the IMbrave 150, in which patients with unresectable HCC, no prior systemic therapy, macrovascular invasion, and or extrahepatic spread, presence or absence, baselines alpha-fetoprotein less or more than 400, are certified 2-to-1 atezo, 1,200 milligram IV every 3 weeks, plus BEVA 15 milligram every 3 weeks, versus sorafenib 400 milligram twice daily, until loss of clinical benefit or unacceptable toxicity. Co-primary endpoints overall survival, IRF assessed progression-free survival per RECIST 1.1. Key secondary endpoint, IRF assessed overall response rate per RECIST 1.1. IRF assessed overall response rate per HCC modified RECIST. This is the patient characteristics, as we see here, and included well-balanced between patients, included patients with which had treated pheresis at baseline, patients with hepatitis B, C, and non-viral etiology, patients with Child-Pugh A5, A6, and Barcelona Clinic liver cancer stage A, B, C. As we see here, atezo plus BEVA in the primary analysis was associated with significantly improved tumor response versus sorafenib, with confirmed overall response rate 27% by IRF RECIST version 1.1, and sorafenib 12, and IRF HCC modified RECIST criteria 33 versus 13. And we had complete responses in 6 patients for atezolizumab and also 10 in the IRF HCC modified RECIST criteria evaluation. The atezolizumab improved progression-free survival, 6.8 atezolizumab versus 4.3 for sorafenib. And as regarding overall survival, in the first analysis, it was not reached, and sorafenib had 13.2. While in the updated overall survival and progression-free survival, which was presented in January 2020 in ASCO GI, we have reached atezolizumab to 19.2 months versus sorafenib 13.4, progression-free survival 6.9 versus 4.3. As regarding updated response here, the confirmed overall response rate was 30 for RECIST 1.1 and HCC RECIST criteria 35% for atezolizumab, with more patients with complete response in the RECIST 1.1, 25 patients, and in the atezolizumab in the HCC modified RECIST 39 patients. So for the first time, we see patients with complete response in HCC according to the atezolizumab trial. As regarding time to deterioration of quality of life, atezolizumab 11.2 versus sorafenib 3.6. These are the adverse events. I'll go very fast. Adverse events with incidence more than 10% in either group. So a very important issue with anti-VEGF therapy, the risk of bleeding. Patients need to remain vigilant about bleeding risk, somewhat higher risk with BEVA than with sorafenib. Most bleeds were non-life threatening, more lethal bleeds with BEVA than with sorafenib. Patients who receive BEVA plus atezo should receive an endoscopy because many patients have variceal bleeding that can be exacerbated by BEVA. BEVA plus atezo does put patients in risk for immune adverse effects. So the summary of the IMbrave 150, which has changed the landscape, and it was the first IO trial in HCC to have an overall survival benefit. Significantly overall survival and progression-free survival with atezolizumab than sorafenib. In the atezolizumab group, median time to duration, quality of life was better for atezo-bevo. Subgroup of high-risk patients, 40% had macrovascular invasion and specifically included patients with main portal invasion or invasion of the portal vein branch. Included also patients with more than 50% hepatic involvement, excluded from other contemporary phase 3 trial. So based on this data, atezo-bevo was the standard of care and approved in May 2020. Additional ongoing phase 3 trials, we have the atezo-cabozantinib trial, COSMIC 312, anti-PD-L1 plus TKI, pembro plus lenvatinib, which is a very promising trial, LEAP 002, anti-PD-1 plus TKI, camrelizumab plus apatinib, tislelizumab versus sorafenib, and the nivo plus ipilimumab in the checkmate 9DW phase 3, durvalumab plus or minus tremelimumab, which is a very important trial, and the Himalaya trial is the largest trial according to the patients in HCC, 1,200 patients. Very quickly, rationale for immunotherapy and TKI combination to overcome the resistance mechanism. Lenvatinib targets VEGFR2/3, fibroblast factor receptor 1-4, platelet-derived receptor alpha, KIT, and RET, while cabozantinib targets VEGFR1-3, MET, tyrosine, AXL, and MIR. We have the phase 1b study, pembro plus lenvatinib, keynote 524, patients with no head and dose escalation evaluation phase, part 1, and expansion phase. No prior systemic therapy. Patients are giving lenvatinib according to the body weight, 12 milligram for over 60 kilogram weight, or 8 milligram for less than 60 milligram, plus 200 milligram pembro. These are the baseline patient characteristics. A very important issue here to look at is the progression-free survival is 9.3 by modified RECIST, while RECIST version 1.1, 8.6. Here, look at the overall survival. I know it is a 1B study. The median overall survival has hit the 20 months bar, and we have now 22 months as regarding overall survival. So this trial was a proof of concept to do the LEAP 002 trial. As we see here, the LEAP 002 trial, lenvatinib plus pembro versus lenvatinib as first-line therapy in unresectable HCC. And as we see, a very important issue here, the control arm here is lenvatinib. In most of in all the trials in first line and second line, first line, if you do a trial in first line, the comparator was sorafenib, and in second line, most of the trials were after progression on sorafenib. So here in the trial, the control arm is lenvatinib alone. Another trial is the trial 117, lenvatinib plus nivo, with an overall response rate by modified RECIST 76.7%, COSMIC 312, cabozantinib plus atezo versus sorafenib in first-line advanced HCC, 2 different doses of cabozantinib, 40 milligram plus atezo, sorafenib 400 milligram twice daily, cabozantinib 60 milligram with a standard dose. Another important trial is the 1B trial of regorafenib plus pembro with multiple treatment dose of regorafenib, 80, 112, and 160. And the disease control rate was 94%. Overall response rate was 29%. Another trial is camrelizumab plus apatinib, the rescue trial. VEGF liver 100, phase 1B, avelumab plus axitinib. And the next upcoming combination is IO, which is combined anti-CTLA4 plus anti-PD-1. The combination of PD-1 and PD-L1 and CTLA4 immune checkpoint inhibitors promotes synergistic anti-tumor immune response using distinct but complementary mechanism and has shown greater anti-tumor effect. This is the tremelimumab plus durvalumab trial, which has part 1 and part 2 and part 3 dose escalation and expansion cohort with different doses of tremelimumab. One dose was 75, and the best dose was 300 plus durvalumab, and a single dose of durvalumab and tremelimumab. And this trial has included, like the checkmate 040 trials, patients who have received sorafenib or patients who are intolerant or refuse to receive sorafenib. So it is this phase 1 trial is a first-line trial and a second-line trial. Again, this trial was very important because the longest median overall survival was observed with tremelimumab 300 plus durvalumab. We have reached, again, median overall survival of 18.7 months for the combination of tremi plus durvalumab. Again, this trial, which is sometimes called Study 22, if we have used it in second line. Again, this trial is a proof of concept for the Himalaya trial, durvalumab plus tremelimumab versus sorafenib, which is a phase 3 trial, and we are waiting for this trial. For me, I think we are waiting for the results of the Himalaya trial and the LEAP-002. And I think the LEAP-002 is the best trial, and I think we will hit the 20 months bar in the results of the phase 3 trial, which will be a breakthrough and will grant a breakthrough designation or approval. Another is the IOIO, anti-CTLA-4 and anti-PD-1, Nivo plus Epi, checkmate 9DW. Again here, the control arm is sorafenib or lenvatinib versus the experimental arm Nivo plus Epi. So what about patients who are not eligible for anti-VEGF therapy in first line? We have checkmate 459, which is a negative trial as regarding overall survival. Nivo 240 every 2 weeks versus sorafenib. What was interesting here, the median overall survival was 16.4, and for sorafenib also was high, was 14.7. But if we look at the tail of the curve, there is durability of response for patients who have received Nivo. So it is an option in first line if we have patients who cannot tolerate anti-VEGF therapy. The comments on checkmate 459, primary endpoint was not met, which was overall survival. PD-L1 not a predictive biomarker. Sorafenib group did remarkably well. We have reached 14 months. Results confirming findings of checkmate 040 in second line Nivo, improved quality of life compared to sorafenib. So would I consider Nivo as first line in advanced SCC? Yes, for those who are anti-VEGF ineligible upfront and who cannot receive a TKI. So if we look here, the evolution of median overall survival at advanced SCC, as I told you before, in the IMPRAVE 150, we have reached 19.3 months. And in the lenvatinib pembro first line 1B study, we have reached 22, and in tremelimumab 300 durvalumab, as you see. So selecting a first line systemic therapy, this is very important. Clinical consideration, prefer atezo plus beva for Child-Pugh class A, no untreated varices, prefer sorafenib or lenvatinib for Child-Pugh B and C liver function, recurrence post-transplant, not a candidate for immune check inhibitors, non-IV administration, case-by-case discussion. So conclusion for the first line, atezo plus beva with positive phase data in the frontline adverse effects, typically for VEGF inhibition, patient factors, liver function and comorbidities, tumor factors, extent of liver involvement and portal vein invasion. For more than 50 liver involvement, we can use lenvatinib. Preference of the patient's shared decision making. This as the second line target therapy. We have regorafenib resource trial, ramucirumab reached 2 for alpha-1 more than 400, and cabozantinib celestial trial, which was used in second and third line. And what is very interesting is the sequence of, according to the resource trial, regorafenib after sorafenib, which have reached 26 months, which is a very good option. So accelerated approval was for Nivo and Epi plus Nivo and Pembro. Rationale for IC, this is a very important issue. What to do after Beva plus atezo in first line. Nivo and Pembro are approved for HCC and target PD-1 instead of PD-L1 atezo, but pathways are similar. Nivo Pembro unlikely to increase activity as single agents after atezo. Anti-CTLA-1 Epi and tremelimumab, single agent activity in HCC targeting different pathways from anti-PD-1, PD-L1. Epi and tremelimumab both demonstrate some activity. Combination with anti-PD-1 demonstrates some response in other tumor types like melanoma, even after progression on an anti-PD-1 or anti-PD-1. So the rationale is for for TKI as second line post-Beva and atezo, regorafenib, cabozantinib, and ramucirumab, alpha-1 more than 400, all demonstrated overall survival benefit in patients treated with prior sorafenib, but was not done for after atezo-Beva. And I was asking this question: should we do another trials? No. We can move treatment options which have approved in the first line, like sorafenib and lenvatinib, to second line, and move the others and choose and put an algorithm for better sequencing of treatment instead on doing another second line trials after atezo and Beva. So we have the keynote 224, Pembro for patients with previously treated HCC. It is a phase 2 trial, and as we see here, patients are studied uninfected or infected with hepatitis C or hepatitis B virus. The overall response was 18%. We had only one patient with complete response, and the median overall survival was 12.9 months. and median progression survival was, and time to tumor progression was 4.9. These are the adverse events. This had led to the phase 3 Keynote 240 trial. Randomization was 2-to-1 in second line after sorafenib, pembro versus matching placebo. And here the overall survival rate was 13.9 months versus 10.6, and progression-free survival 3 versus 2.8. Checkmate 040, as I told you, had many cohorts and was studying a very important issue. Does the viral hepatitis has an impact on the use of checkpoint inhibitors? Because there was a theory which has postulated that immune check inhibitors can flare the underlying hepatitis inflammatory condition, but this was not shown in the trial. Again, the trial had two parts: patients who have received sorafenib and patients who were intolerant to sorafenib. Again, these are the demographics and safety escalation. Here, as we see, sorafenib naive patients have shown an overall survival 28.6 in this phase 2 trial, and sorafenib experienced patients, the median overall survival was 15.6. Second line nivo plus epi, again from the phase 1 and 2 checkmate 040 trial, randomization 1-to-1 nivo 1 milligram, epi 3 milligram, and remember always epi is used for only 4 weeks. And the second dose was nivo 3 milligram, epi 1 milligram, and the third one was nivo 3 milligram and epi 1 milligram every 6 weeks. Here, the best overall survival was for arm A with nivo 1 milligram, epi 3 milligram. We have reached an overall survival of 22.8 months. This is the adverse events. Another study is study 2, which I have explained before. The median overall survival was 18.3 months. 18.70 months for Tremi 300 plus durvalumab. So selecting a second line systemic therapy clinical consideration, TKI, but which one? Sorafenib or lenvatinib as if first line, regorafenib or cabozantinib as if second line, local therapy, resection or other regional therapy if successful down stage after treatment, and immune check-based therapy, untested in this setting. Data from other cancers suggesting targeting another checkpoint may be beneficial. So, immune check inhibitors in the second line setting for advanced HCC. Would I consider immune check inhibitors in the second line for advanced HCC? Yes, if short duration of response. Intolerance to first line TKI therapy. Single or dual immune check inhibitors in the second line setting, likely single agent anti-PD-1 due to increased risk of toxicity with dual agents, but if fit and response needed, may consider dual agents. Immune check inhibitors in Child-Pugh P7 and 8, nivo may be used cautiously. This is a summary of second line services advanced SCC, regorafenib, cabozantinib, ramucirumab phase 3 trials, accelerated approval for nivo and pembro and epi plus nivolumab. So how should we sequence systemic therapy in HCC? Sorafenib and lenvatinib have only been tested in first line. Ram and regorafenib, cabozantinib have only been tested in second line after sorafenib. So our postulated algorithm is concept 1, atezo plus biva. We have option in first line lenvatinib plus sorafenib. So option after atezo biva, we can move sorafenib and lenvatinib after atezo and biva, and then standard after sorafenib, and option after lenvatinib, cabozantinib, regorafenib, ramucirumab. And the best algorithm is if patients have tolerated sorafenib to give in third line regorafenib according to the resource type. Concept 2, atezo plus biva in first line, option lenvatinib or sorafenib. And then we can have standard after sorafenib, cabozantinib, regorafenib, ramucirumab according to the phase 3 trials. Option after atezo plus biva, sorafenib or lenvatinib, again, as I told you, or cabozantinib and ramucirumab. And options after lenvatinib, sorafenib or cabozantinib and ramucirumab. So Child-Pugh class B cirrhosis, as I told you, there was a study comparing nivo, which showed some activity in Child-Pugh class B cirrhosis, and also the other drug is sorafenib, which has been studied in patients with Child-Pugh B7. So Child-Pugh B is a challenging issue, and we have only nivo and sorafenib in Child-Pugh cirrhosis. This is the ASCO guidelines for managing immune-mediated hepatitis, and I think my colleagues will cover it very thoroughly. So a very important issue is the incidence of anti-drug antibodies developing with different immune check inhibitors, and the highest antibody-drug antibodies was with atezo, which had reached 54.1%, then nivo, then epi, then avelumab and durvalumab and pembro. So my conclusion, and I'm very sorry because this is a very rich topic. I'm sorry for being late. My conclusion is HCC is an immunogenic disease. Combination of a molecular target therapy and IO therapy improves response and survival. Patient selection is the key to derive optimal benefit. Poor ECOG performance status or poor liver function is not an excuse to give immune checkpoint inhibitors, but can be used cautiously. Molecular target therapy remains a good treatment option for advanced HCC patients. Refer for systemic therapy early to prevent deterioration of liver function. Important to work closely with hepatologists to manage underlying liver disease. Multidisciplinary team effort is the key. Thank you for your attention.
Thank you, Professor Yassin, for this hot topic. Actually, I remember 4 years ago, we have only sorafenib for treating HCC. And now we have a big portfolio to treat HCC, thank God. Now the floor is open for any question from the faculty or from the attendees. Please, if anyone want to ask Dr. Yassin about the topic, please to send the question in the Q&A, please. Actually, Dr. Yassin, till we receive a question from the attendees, I have a question for you. You think lenvatinib and sorafenib will be effective after Biva Atezo?
As I told you, this was not studied in phase 3 trials, but I've asked this question many times before, especially to Professor Richard Finn, who was the PI of the IMBRAVE 150, and asked him, yes, should we do other trials after failure at Atezo-Biva? He told me, we will never do that. We will invest our resources in first-line trials with new combinations, as I told you, the COSMIC 312, LEAP 002, and we have to move lenvatinib and sorafenib for second line, which can be a good option. There might sorafenib and lenvatinib are TKIs, and although they share some activities like other TKIs, but the mode of action is different. Remember, Atezo is IO, Biva is anti-VEGF. Although TKIs have anti-VEGF activity, but they target another target like c-MET, AXL, fibroblast cause factor receptor, which are responsible for the HCC. So they will retain activity in second line, yes.
Okay, and from your experience, you tried another immune checkpoint inhibitor after Atezo-Biva?
Still, I didn't. I have some patients ongoing on Atezo-Biva. Still, they did not progress. But as I told you before, it is not logic to use another IO after the failure of Atezo-Biva. It is reasonable to use a TKI, which was not used in second line. Yes. But as I told you, there's no head-to-head trials, and these are only postulations from different disease areas in which we have studied IO. Also, in melanoma and some other subtypes, patients have received different IO plus anti-CTLA-4 after progression on first-line IO. Yes.
Okay. Thank you, Dr. Mohammed. We didn't receive any question from the attendees. I will just now I'll move now to the next speaker. Our next speaker is Dr. Mohammed Ashour. Dr. Mohammed Ashour is a consultant of clinical oncology at Al-Azhar University, Cairo, and now he is working as a consultant of radiation oncology in Kuwait Cancer Control Center in Kuwait. Dr. Ashour will give us a lecture about IO and head and neck cancer. Dr. Ashour, I'd like to welcome you, and please you can start your talk.
السلام عليكم. سامعني كده يا دكتور احمد؟
وعليكم السلام ورحمه الله. اتفضل يا فندم، اتفضل.
Thank you, Dr. Ahmed, for this great meeting and organization, and thank you for invitations. I'm happy to be here with our colleagues in Egypt. My task today is to talk about the evolving role of IO in recurrent or metastatic head and neck cancers. Head and neck cancers have many lines. We have many lines in treatment, but I will talk mainly about the first line and a little bit about the second line. My objectives. And head and neck cancer is a diverse disease. It's sharing the same anatomical side, but the natural history of each disease is different. The behavior of the disease is different. The incidence of the disease is different. The distribution of the disease worldwide is different. We can see oral cavity the incidence #1 worldwide and USA. However, the nasopharynx, this is a very rare disease in Europe and in USA, while in China, in Middle East, in Asia, it is more common. So we are dealing with different diseases. Each disease should be dealt with as a special disease. The main task of the treatment, or the main one of the main pillars of the treatment of head and neck cancer is to use the MDT meeting. MDT meetings not only improve the quality of life, but improve the survival of the patients. So we share all the specialties that may lead to outcome, better outcome. So the advice of all doctors or all specialty working in this field is to use MDT, especially in head and neck cancer treatment. The treatment of metastatic or recurrent head and neck cancer, cisplatin is a pillar. Cisplatin has been since discovery from 1977, 1985, and remain that until 2008, where extreme regimen come, adding cytoximab to platinum, that improves the survival 2.7 months, as you see in this curve. This remained for a long period as the standard of care until 2019.
Yes. دكتور عاشور السلام، معلش انا اسف على الانتربشن. حضرتك بس ممكن نعمل شير سكرين لان البرزنتيشن مش واضحه قدامنا.
طيب اوكي حاضر.
نعمل السهم الاخضر اللي تحت.
انا عارف، انا عملت شير سكرين.
لا بس هي ما ظهرتش قدامنا يا فندم.
حاضر.
تمام
طب كده تمام؟
بس هي لسه. ايوه تمام. حضرتك بقى
اكبرها لك. حاضر. تمام.
انا اسف على
كده تمام.
اتفضل يا فندم. تمام يا فندم اتفضل.
طيب I will go through this is the first slide and the rule. What is I talk about the incidence and diversity of the disease and the MDT discussion, the role of MDT discussions in the treatment, and now the cisplatin and the role of cisplatin in the treatment until the discovery of cytoximab, or the enrollment of cytoximab in the treatment of in 2008, and this is leading to overall survival of 2.7 months. And as you see in this curve, this is a great benefit and remain one of the standard of care in the first line for 1 decade until 2019. And you see in this slide, this a study retrospective analysis done in about 71 centers in Europe and USA. The aim of this study to show the clinical practice of each centers, what treatment they are dealing with. What is the treatment? As you see, the treatment mainly based on platinum, and the most the great the first #1 in the treatment is the cytoximab or extreme regimen. However, the conclusion of this study shows that choice of therapies of patients with recurrent metastatic head and neck cancer varies across countries and in routine clinical practice, and the prognosis is still poor and with limited therapeutic options. Recently, we have developed the development in immunotherapy in the treatment, and we have a great achievement in many diseases and in head and neck cancer also. As you see in this slide, there are many immunotherapies under investigations and approved in head and neck cancer, from antibodies or checkpoint inhibitors to vaccine and to anti-HPV, many lines. But I will focus my treatment today about the checkpoint inhibitors, the PD-1 and PD-L1 in the first and the second line treatment. The rationale or the base of the treatment, as you know, the tumor usually targeted, or the T cells, our immunity targets the tumors, try to kill the tumors by tumor T cell tumor interactions or T cell interactions. These interactions is insufficient to kill the tumor, and many ways tried from decades to use the interferon, to use the interleukin, to use the BCG in many diseases to improve the immunity, and sometimes fails and sometimes succeeds until this mechanism of action of immune checkpoint inhibitors come and appear in the ground. And the main idea here is to inhibit the inhibitory effect on between T cells and tumor, either to inhibit the CTLA4 that has high affinity to B7, leading to stimulation of immune cells or immunity against the tumor, or inhibitions of PD-L1 or PD-1, leading to stimulations of immunity against the tumor. This response, the response of the tumor to checkpoint inhibitors, depend on many factors. One of the most important factors is the degree of mutations. As you see in this slide, many diseases ranked according to the degree of mutations. The head and neck cancers ranked having 75 mutations, which considered is one of the highest tumors can respond to the immune checkpoint inhibitors. Many factors may be interfere or may be influence the use of checkpoint inhibitors in head and neck cancers. PD-L1 is one of the important tests now. This may be choose the basic immunotherapy for first line. B16 is a marker for HPV, but it is not has no role in treatment of head and neck cancer, but has a role in prognosis in head and neck cancers. Other many factors like age and performance status, disease-free intervals, and tumor burden, and the need of rapid tumor shrinkage, very important, these factors. And this is the last ESMO guideline in 2020. Financial factors should be considered. Also, the PD-L1 positivity and the degree of positivity, it is more than 1 or more than 20 or less than 1. And another factor, the B16 as a growth factor in oropharyngeal cancer, TMB, one of the evolving markers now, and gene signatures is still under investigations. In first-line treatment, we have many trials, ongoing trials and released trials. One of the important trials is the Pembro or Pembro chemo versus extreme keynote 48. I will talk about this trial in details. One other trial is the durvalumab, tremelimumab, which is a crystal trials. The durvalumab is PD-L1 inhibitor, tremelimumab is CTLA4 inhibitors, versus the chemotherapy extreme regimens, which came negative trial released in last month as a negative trial and does not improve survival. The famous Keynote 48, which is phase 3 randomized controlled trials, 3-arm APC, the arm A, pembrolizumab single agents, arm B, pembro plus chemo, arm C is chemo alone for patients with first squamous cell carcinoma, head and neck cancers, recurrent or metastatic, incurable, good performance data 0 to 1. They are testing for PD-L1 and for B16. The aim, the primary aim of this trial is to test the overall survival and the progression-free survival in total populations and in CBS more than 20, in CBS more than 1. And the second endpoint, many second endpoint, including the response rate and the quality of life. As you see in this table, the baseline characteristic of both groups, the 3 groups, is well balanced. They are testing, they are discussing many points or many factors between 2 groups. The result of the trials, I will say now the results between pembrolizumab as a single agent against chemotherapy. At first, as you see in single PD-L1 in CPS score more than 20, there is improvement in overall survivals with good hazard ratio 0.6 and p-value not only after 24 months, but also after 48 months, 2 years. The survival after 48 improved from 8% still alive in control group, or 20% still alive in control group. The CPS score more than 20 is the same results with less overall survival 0.7, and there is improvement in both groups, either CPS more than 20 or CPS more than 1. While the total populations in this group of patients, you can see in this curve, in the first 6 months, the chemotherapy did better than the immunotherapy in the total populations. Until after the 6 months, the immunotherapy start to be having better results, while the overall survival is still insignificant with hazard ratio 0.8. This is the pembro alone against versus the chemotherapy. While if we look at the toxicity of this group of the study, the pembro is well tolerated. The toxicity is, I think, accepted, and the patients can go smoothly and treated smoothly without any side effect. The other group of this trial, pembro plus chemo versus chemotherapy. As you see in this curve, this is a total population. If you remember the last curve of pembro as chemotherapy, the first 6 months here is no difference between both groups. The chemotherapy and the chemotherapy plus pembrolizumab start to differentiate at the 6 months, and the chemotherapy, the pembro are having better overall survival, improved from 10.7 to 13 months, and the hazard ratio 0.7 with p-value, significant p-value. This significant is more better in CPS score more than 20 and in CPS score more than 1, as you see in this curve and in long updated results after 4 years. We can see this subgroup analysis, we should take in our considerations this subgroup analysis. In patients with CPS score 0 or less than 1, you can see the chemotherapy arm did better than the immuno arm in patient with in the group received pembrolizumab alone. While in the group received pembrolizumab plus chemotherapy, the difference is not great. It is 11 months versus 10.7 months, and we can say it is more or less equal. The toxicity in the group of pembro plus chemo, we can see it is equal to the chemo. Therapy is a grade 3 or 5 toxicity, 70%. In both groups, 69 versus 70, it is the same, the toxicity, but it is more toxic. But the difference here is the duration, the duration of response is better for pembro arm, and the response rate here in the pembro plus chemo is equal to the chemo arm, while in the group of pembrolizumab alone, the response rate is less than the chemo arm. This trials, this history led to this graph of treatment. If we need rapid tumor shrinkage, and if you have patient with advanced disease with many metastases, and we need rapid tumor shrinkage, and we don't have CPS score. If we don't have CPS score, we can go directly to chemotherapy plus pembrolizumab. In this treatment, we have a better survival, and we have a good response rate, and we have a good duration of response. But if we have a CBS score, we need to test the CBS score. If it is more than 1, it is directly to go for pembro and the chemo, and this is the standard of care. But if the patients have 0 or less than 1, the chemotherapy is doing the same as pembro plus chemo, so you can escape or avoid the financial toxicity and give the chemotherapy plus cytoximab. On the other group, if the patient is stable and asymptomatic, we need to do the CBS score. If the CBS score more than 20, so these patients having great benefit from pembro single agents. But if the patients having CBS score more than 1 and less than 20, pembro, you can give pembro or pembro plus chemo. If the patient having a BS score, CBS score less than 1 or 0, chemotherapy is a best for these patients, and this is according to the curve we saw before. In second-line treatment, we have this table summarize most of the trials, and we have 2 important trials: the Checkmate 148-1 and the Keynote 40. The Checkmate 149 of nivolumab. This is anti-PD-L1 on about 360 patients. Nivo in 1 arm and versus standard of care chemotherapy, dosi, cytoximab, bezotrexate in the other arm. And you can see the overall survival benefit of nivolumab in second line, 7.5 months versus 5 months with hazard ratio 0.7, and this lead to approval of this drug in FDA and in EMA, regardless of PD-L1, without PD-L1 status. While if we go to the other trial, the Keynote 40, PD-L1, anti-PD-L1, about 500 patients, pembro in 1 arm versus the standard of care chemotherapy. Initially, these trials came negative and didn't meet the primary endpoint. The overall survival, 8.7 versus 7 months. But we can comment on this result initially. If you go to the control arm here in Keynote, it's 7 months, and to go back to the control arm of Checkmate 141, it is 5 months. So the control arm of Keynote doing better or did better than the control arm. This makes the difference in the results. In addition, in this trial, there is a crossover between the arms. This decreased the benefit of pembro in this arm. So this trial was negative and was positive only in patients with CPS score more than 50. This lead to approval of this trial in FDA, in EMA, in patients with CPS score more than 50. But in EMA, they approved, in FDA approved the pembro according to the trial of phase 2 trial Keynote 012. This is the first trial approved, taken accelerated approval, and still approved pembro in the second line according to this trial. And if we go back to the further follow-up of the Keynote 041, the curve become more significant and the overall survival become on long run. The other trial, the Eagle trial and Checkmate 714, is a negative trial. This trial of durvalumab plus tremelimumab versus durvalumab versus standard of care, or nivo-ipi versus nivo. Both are negative trials in the second line. This is a curve of Checkmate 141 in overall survival. We can see the hazard ratio of 0.68, and this is the curve of Keynote 40 in the second line. The difference, this is the initial results, and the updated results, it become positive in long run. Finally, I will summarize my talk in this slide. This is the recommendations of ESMO in 2020 released finally. We can say if we have patients no platinum, had not received platinum before during the last 6 months and PD-L1 positive, we can choose pembro monotherapy or pembro plus chemo. If we have patients with no platinum chemotherapy during the last 6 months, PD-L1 assessment not carried out, pembro plus chemo. If we have patients no platinum chemotherapy during the last 6 months and the tumor negative for PD-L1, chemotherapy, extreme regimen. In the second line, if we have patients with pre-treated with platinum-based chemotherapy within the last 6 months and immunotherapy in the last 6 months and immunotherapy naive didn't receive nivolumab or pembro. While if we have patients pre-treated with platinum chemotherapy within the last 6 months and with prior immunotherapy, chemotherapy in the second line, taxane, whatever you can give, all the same results and does not improve the overall survival, just to improve the quality and to give some progression free. And finally, I will finalize my talk and thank you, Dr. Ahmed, for your invitation.
Thank you, Dr. Ashur, for this excellent lecture. The floor is open for discussion. Actually, we received two questions for Dr. Mohammed Yassin, the previous speaker. The first question is for patient on atezolizumab. He received 9 cycles, and after this, due to esophageal varices, he has hematemesis. You think after controlling the hematemesis, you can recontinue the BIVA again?
First, we have to define who is the cause. Before starting atezolizumab, you have to do endoscopy and treat any varices before starting atezolizumab. So if you have previous varices and this was exacerbated by atezolizumab, so you have to stop and you cannot resume atezolizumab after that. But if the patient didn't have any bleeding tendency or any varices before starting with atezolizumab and then he developed varices or started bleeding and you have controlled it, you can continue atezolizumab after controlling. And remember, many patients in the atezolizumab trial had previous varices but were treated before. So treatment first before continuing atezolizumab. Yes.
Okay. The second question, he was asking about the portal vein thrombosis in the era of immunotherapy. He said that in the CHARP trial, the sorafenib get an overall survival benefit for patient with portal vein thrombosis. What about the immunotherapy? I think immunotherapy is the best.
Yes. As you have said, patients with portal vein thrombosis was not an exclusion criteria in the IO trials. Never. The only exclusion for IO is, as we all know, patients with previous transplantation, autoimmune diseases, myasthenia gravis, and so on. And for the combo, by the way, IO alone is only approved in second line because it didn't show any overall survival. So you have to look at the adverse events of IO plus the combining TKI or anti-VEGF. This is very important, yes.
Thank you, Dr. Yassin. Thank you, Dr. Ashur. We didn't receive any more questions now. Now we'll, due to urgent situation with Dr. Abdelhadi, he apologized to give the lecture, so we'll shift immediately for the symposium of Bristol Myers Squibb. And I'd like to introduce my dear colleague and friend, Dr. Nawal Tuhami. Dr. Nawal Tuhami is a consultant of clinical oncology at Electricity Hospital, and she previously a doctoral fellow at Ain Shams University. Dr. Nawal will give us a talk about real-world experience with Nivo in treating 2L metastatic RCC patients. Dr. Nawal, you can start, please. Unmute your mic, Dr. Nawal, please.
Okay. Assalamu alaikum.
وعليكم السلام ورحمة الله وبركاته.
Good evening, my dear brother, Dr. Ahmed. Thanks for your introduction. Good evening, my dear professors and colleagues. I'm really honored to join this great event. And thanks for the kind invitation from the meeting and from BMS. I will do a full screen first. Is it clear now?
Yes, Dr. Nawal.
Okay. I will talk today about my experience regarding nivolumab in treating patients with in the second-line treatment metastatic renal cell carcinoma patients. This is my disclosures, and I will review the data of nivolumab in second-line treatment through a real case. 58 years old male patient with a good performance status ECOG 1, presented on 2014 after left partial nephrectomy, revealed renal cell carcinoma clear cell type. He kept on follow-up until October 2017 when he developed a recurrence of the disease and lung metastasis. So based on the evidence and the guidelines at that time, November 2017, he started sunitinib. The patient continued on sunitinib with a good response and a well-tolerable treatment for 2 years until August 2019. He developed progression of the local recurrence and cervical mediastinal lymph node metastasis. So this is our topic. What about patients who received a TKI in first-line renal cell carcinoma clear cell type, then progressed upon? What is the recommendation? First, I will review the metastatic renal cell carcinoma as a disease and the disease burden of it. Although the majority of the patients with renal cell carcinoma presented with a local disease that is treated with a local resection, still there is 30% of the patients presented with a metastasis at the diagnosis. And according to the worldwide incidence based on 2018 worldwide statistics, renal cell carcinoma is the 14th common cancer and the 16th cause of cancer death. So the death due to renal cell carcinoma is higher than the incidence itself. So we have a highly aggressive disease with a 5-year survival of only 12%. And one of the very important steps to do before starting treatment in metastatic renal cell carcinoma is to calculate the risk category of the patient. The most widely used prognostic criteria is the IMDC criteria. And although it is developed in the TKI era, it is still used in the clinical trials. And it is categorized patients into favorable, intermediate, and poor risk patients. And this risk is reflected on the overall survival, with the longest overall survival with the favorable risk patients, then the intermediate, and finally the poor risk has the shortest overall survival. And the story of the metastatic renal cell carcinoma patients management started before this century with the introduction of the interleukin-2. And the response or the overall survival of the patient on interleukin-2 was correlated with the response. This is the beginning of the treatment. Then with this, the beginning of this century, we have the approval of the anti-angiogenic TKIs in the first-line and second-line RCC patients. And this leads to improvement in the overall survival in all risk patients, either good, intermediate, or poor risk patients. All of them get a benefit with the anti-angiogenic TKIs. And until 2015, we don't have except the anti-VEGF TKIs and the everolimus as an mTOR inhibitor. We usually use it as a sequential, a monotherapy in a sequential way, either to start with TKIs in the first line, sunitinib or pazopanib, then mTOR in second line, then TKIs again in third line, axitinib or sorafenib, or to start with sunitinib, pazopanib in first line, then another TKI in second line, then everolimus in the third line. That's all what we have until 2015. And by the use of the anti-angiogenic TKIs in first line and second line RCC, we reached up to 30 months in the first line and 18 months in the second line. This is what, this is where we are, and this is where we are now. With 2015, we have the result of the CheckMate 25 and the approval of nivolumab in the second line treatment of RCC, metastatic RCC. And this opened the door for the idea of using immune checkpoint inhibitors in the renal cell carcinoma, not only in the second line treatment, but also in the first line treatment, either as a combination with TKIs like pembrolizumab, axitinib, and avelumab, axitinib, or immuno like nivolumab, ipilimumab. And this is move the treatment of metastatic renal cell carcinoma from the dark to the golden age. So this is the story. It started by 1992 with interleukin, going through the TKIs, sorafenib, sunitinib, axitinib, and then the nivolumab in 2015, and then multiple approved line in first line RCC are settled, and there is more and more ongoing combination. We are waiting for its result in the first line treatment. And I want to highlight about the mechanism of action of nivolumab as an anti-PD-1. PD-1 is a receptor that's found on the activated T cell. Activated T cell, its role is to kill the tumor or to do the immune response against the tumor. And the tumor had a PD-L1 receptor. That when it is bind with PD-1 receptor on the tumor or in the activated T cell, that will cause suppression of the T cell and inhibition of the immune response against the tumor. The action of nivolumab is binding with this PD-1 that will inhibit the binding of PD-1, PD-L1 pathway. So I will inhibit the inhibition. By other way, I will maintain the stimulated T cell and its effect against the tumor cell. This is the approved medication all through the years in the metastatic renal cell carcinoma. We used to use a monotherapy in either first or second line treatment. Then we have now, after the approval of nivolumab in the second line treatment, we have many approved combination in the first line treatment, and many promising combination will be approved, I think, in the next years. This is the result of the CheckMate 25, the longer follow-up after 5 years. CheckMate 25 is a randomized phase 3 trial comparing nivolumab versus everolimus in the second line treatment of renal cell carcinoma patients. And the longer follow-up revealed a significant prolongation of the overall survival, as a median overall survival was 25 in nivolumab arm versus 19.7 in everolimus arm. And the 5 years overall survival was significantly higher, 26 versus 18 for everolimus. And I want want you to look to the separation of the curve that occurred as early as the early months of treatment. Also, the progression-free survival was significantly higher as for 5 years progression-free survival, 5% versus 1%. And the overall response rate was significantly and much higher with nivolumab, 22.9 versus only 4.1 for the everolimus. And response rate means control of the symptoms of the patient. And this control is not an event for a moment, it is a durable response. The duration of response was also higher with nivolumab, 18.2 versus 14 for everolimus. And regarding the quality of life, also nivolumab had a better quality of life versus everolimus. And this, to me, is a real happy story that I usually see in my clinical practice, especially for patients who received TKIs in first line, like here, the renal cell carcinoma, and like patient with hepatocellular carcinoma who received a TKI in the first line treatment. Then with the progression, the patient received nivolumab as a second line. Quality of life was dramatically improved. I see it with my eyes. The very, very annoying adverse event like hand and foot, which usually enable the patient to have a life without pain, is very annoying with TKIs. When we shift to nivolumab, this adverse event was no more found. The patient came with a different face, and this is a very true and happy story, the improvement in quality of life. And this is usually due to the less adverse event occurred with nivolumab in comparison to everolimus, especially grade 3 and 4 adverse event was less with nivolumab versus everolimus. And due to this all, the NCCN guideline put nivolumab as a category 1 for patients with second line clear cell metastatic renal cell carcinoma. So to summarize, at CheckMate 25, we have a drug, nivolumab, that causes improvement in overall survival, not only the median overall survival, but the 5 years overall survival was significantly higher with nivolumab. The 5 years progression-free survival was also significantly higher. The objective response rate was much higher, and the longer treatment-free interval among responders were without any further treatment was higher with nivolumab, and this is because of the delayed response that I see it more than one time in many patients. And we have a lower grade 3 adverse event, and we have improvement in quality of life. So based on that result, our patient received nivolumab in July 2019. And after 3 months of treatment, the patient gets a complete disappearance of the tumor in the recurrence, and a more or less stable disease in the mediastinal and cervical metastasis. And after 6 months of treatment, the patient had a free PET-CT of disease. There is no local recurrence anymore, and complete disappearance of the mediastinal and cervical lymph node. This is the result. What is the price? I mean the adverse event. The immune-related adverse event is completely different from what we used to see with chemotherapy or TKIs. I mean that the adverse event can occur occurred in any part of the body, from the head to toes. Any part can be affected: the skin, liver, kidney, joint, muscle, eyes, everywhere in the body can be affected. So what can we do? First of all, we have to monitor this adverse event carefully in every time the patient came to take his medication. First, by history, not by asking the patient what you are complaining, what occurred during the last 2 weeks, if we give nivolumab in 2-week schedule, or during the last month, if we have it monthly. No, the patient may complain from one of these symptoms and he didn't mention, as he didn't correlate between the symptoms and the drug. So we have to ask the patient about symptoms by symptoms. If he had a diarrhea, if he had cough, if he had dyspnea, if he had weakness, if every symptoms by symptom, plus or minus. And not only that, we have to differentiate between the immune-related any itis in the body and other cause of itis, as there is many other cause for any inflammation. The patient with immune-related pneumonitis, for example, may the symptoms is similar with pneumonia, for example. We have to differentiate between the other differential diagnosis with the immune-related adverse event. And we have not just to take a history, we have to examine the patient. The patient may develop the skin rash and he didn't observe it, especially if it is in his back or his trunk. And many immune-related adverse event is not clinically can be catched. We have to do a laboratory test to get it, like hepatitis, pancreatitis, nephritis, and especially the endocrine-related adverse event. We have to test TSH level at the beginning of treatment and regularly during treatment, and not by the end of treatment we stop asking the patient or following the immune-related adverse event. No, we have to continue even after stoppage of treatment. I have a real case that developed uveitis after stoppage of after 3 months of stoppage nivolumab. So first, we have to educate the patient about the adverse event or the caregiver. For example, you may develop diarrhea, when to take a home medication and didn't ask for help, and when to came to an unscheduled visit, when to came to the emergency without any delay. This is very important. And when we catch this adverse event, we have to grade it, even grade 1, 2, 3, or 4. With grade 1, we didn't do any intervention. We just observe and continue treatment. If the patient developed grade 2, we have to stop treatment until recovery to grade 1 or less. Then we and give a steroid. Then we restarted after recovery. And if the patient developed grade 3 adverse event, we have to interrupt and give a high dose steroid that must be tapered in 1 month duration, not less than 1 month duration. As if I stop a steroid in a period less than 1 month, then the patient may represent with the same symptoms again, shortly. And if the patient developed grade 3, we permanently stop treatment and don't forget to monitor the treatment even after the adverse event, even after stoppage of treatment. Return to our case, the patient developed grade 2 diarrhea for the first time. We interrupt and we give him a symptomatic treatment and steroid, and we taper the steroid over 1 month. And again, when we resume treatment, he developed another grade 3 colitis. So we stopped treatment forever. At that date, March 2020 was the last dose of nivolumab. And the patient continued without any active treatment, as his PET-CT was free of any disease for more than 6 or 7 months until the end of this year, when he developed a reactivation of the disease and progression, and he is now on axitinib. His performance status is still good with ECOG 1, and he is doing well on axitinib. By this, I reached to the end of my presentation. Finally, I want to thank my beloved team, Electricity Hospital Oncology team. Thanks for the effort and the care of the patient every day. And finally, thank you, and for any questions. Thank you.
Thank you, Dr. Nawal, for this nice presentation about RCC. Actually, I will ask you a question about how you the first line. We have a pool of first line for XC, for RCC patients, a lot of immunotherapy, combo immunotherapy, TKIs, combo TKIs, immunotherapy. So, from all these data, how you are selecting the first line for your patient?
First of all, as I have said, we have to calculate the risk group of the patient. If I have a favorable risk group and the patient is asymptomatic, I prefer to go for TKIs, the regular TKIs, sunitinib or pasritinib. And if the patient a favorable risk group and need a rapid response and he is presented with a symptomatic disease, I prefer pembrolizumab, as it is the only combination that had a positive overall response rate in the favorable risk patient. If I have a patient with intermediate or high risk, I will go through either pembrolizumab or ipi-nivo. Until now, we didn't have the ipi in our country, so the available option is pembrolizumab. This is as a first line treatment. As a second line treatment, if I have patient who is received sunitinib or any TKIs in the first line treatment, nivolumab is the best for the second line treatment.
Okay, thank you, Dr. Nawal, for this. I think we have a question for Dr. Muhammad Ashur. I don't know if he's still online with us. Dr. Ashur? No, I think he left. So if any one of the attendees want to ask Dr. Nawal any question about her nice presentation about the second line treatment of metastatic RCC, he's welcome. So I think by this we will shift to the next speaker. Our next speaker is Dr. Amr Shafiq. Dr. Amr Shafiq, assistant professor of criminology university. Actually, he was my senior during my residency. Dr. Amr, he will give us a talk today about the IO combination in solid tumor. Dr. Amr? I think Dr. Amr has a problem in the connection. I will give him a couple of minutes. Until Dr. Amr solved the problem he has, I'd like to remind all my colleagues, professors, and the attendees that tomorrow, inshallah, we'll have day 2 of our meeting. Tomorrow, inshallah, we have a lot of great speakers like today. We will have Dr. Joaquin Belmont, who will give us a keynote lecture about managing urothelial carcinoma with IO, and we have Professor Tahir Tuijiri from Hospital, who will give us a talk about the IO in breast cancer, especially triple negative disease. We have I think a great presentations will be from three of our colleagues in Ain Shams University, Dr. Ahmed Hassan, Dr. Maya Azdin, and Dr. Ahmed Saeed. The three of them will give us a comprehensive talk about the managing lung cancer by IO. They will start from the first line non-small cell lung cancer, then the second line, and then they will go through the small cell lung cancer and mesothelioma. And finally, we'll talk about the toxicity of managing the toxicity during IO therapy. And then we'll give some case presentations about IO therapy in real life. I think Dr. Amr now is with us online. Dr. Amr. He sent me on WhatsApp that he needs 30 seconds. So sorry for this unforced delay. Tomorrow, inshallah, we will start at 6 p.m. Cairo local time, 7 p.m. 7 p.m. Saudi Arabia local time. Inshallah, I hope we have you all with us tomorrow. Also, considering the questions, all the attendees are welcome to send their questions online, and if we are able to have a reply today, we will do it. Otherwise, we will give the answer tomorrow, inshallah. But send your questions, and we will try to answer you today or tomorrow, inshallah. Also, I'd like to remind you about our, inshallah, next meeting, which will be the 8th virtual meeting by the EMOG group. It will be about prostate cancer. It will be in the 8th of April, inshallah, Thursday, 8th of April. It will be from 6 to 10 p.m. We are honored to have honorary president and chairman of this meeting, our dear Professor Lubna Azz Al-Arab from Ain Shams University, and our dear colleague, Dr. Ahmed Ali Ubay from Zagazig University, inshallah. I think now Dr. Amr solved the problem and he's online. السلام عليكم دكتور عمرو.
وعليكم السلام دكتور أحمد. ازيك الأخبار؟ كله كويس؟ I'm sorry for being late. I have another meeting. والschedule بس كان اتغير شوية.
Okay,
I don't want to
just inshallah, Dr. Amr will give us a talk about IO combination in solid tumors. Dr. Amr is assistant professor at Ain Shams University. And not to be late more, Dr. Amr, you can start now. Thank you.
Okay, thank you, Dr. Ahmed, for this nice introduction. I will start my presentation by sharing. Okay, great. So I will just proceed. So my talk today is about the clinical value of dual IO combination in cancer treatment. I have observed some of the talks that was said today. So we had tackled a lot of talks about immunotherapy in a lot of indications. Immunotherapy is a pivotal development in the practice of oncology. And my talk per se, it will be about the dual IO combination in this arena. So this is my disclosure. The introduction of IO therapies has generated a paradigm shift in oncology treatment. So we have had surgery, radiation therapy, chemotherapy, and targeted therapy for a while. And now we are having immunotherapy. If this is a chemotherapy survival, this is like a cartoon for the survival versus time with chemotherapy. Then we have targeted therapy, a little bit improvement. IO is sending the curve up a little bit. Our hopes is that with the combinations of IO and with other therapies, either chemotherapy, other targeted therapy, and with another IO, it will elevate the combination therapy survival curves into a higher level. The immunocycle, this is a very basic in understanding the role of immunotherapy in oncology. The immunocycle starts with the antigen release from the tumor or whatsoever, and then the antigen presentation either on the tumor or by antigen presenting cells, followed by priming, activation, followed by trafficking of the T cells and tumor infiltration through the vessels into tumor recognition and attaching it, and then the final step of tumor killing. This is a perfect scenario, and we're going to discuss how we're going to handle this circle. So the combination therapies can act on various steps of the cancer immunity cycle, providing a rationale for IO combinations. So those are exact 7 steps that we have discussed before in the previous slides, and I'm going to pinpoint where exactly I believe that each of our treatments will settle in. So when we talk about the first of the antigen exposure from the tumor, we know that chemotherapy, radiotherapy, and target therapy can succeed in releasing more cancer antigens, and this would be a rationale for the using of combining chemotherapy and other targeted therapy and radiation with immunotherapies or checkpoint inhibitors. Cancer antigen presentation can be provoked by use of vaccine therapies. The priming and activation can be done by an anti-CTLA-4 inhibition, and this will be discussed thoroughly in this presentation. Of course, trafficking of T cells by chemokine modulation. Infiltration of T cells can be used by addition of an anti-VEGF example, like bevacizumab, for example, that will give a synergistic effect with an IO. Recognition of cancer cells by T cells, which is simply the CAR T therapies, and of course the killing itself of the cancer cells by the anti-PD-L1 and anti-PD-1 therapy. The key phases of adaptive immune response. So adaptive immunity develops when the body is exposed to an antigen over time and builds a defense that is specific to it. This happens through a cascade of action. First, the antigen recognition at day 0, for example, and then the cell activation. With cell activation, clonal expansion of the T cells will start to increase in number, in values, and then the antigen elimination. Through its action, it will start eliminating the antigen, and the humoral immunity and cell-mediated immunity will interact. In the end, the number of the T cells will be in surplus, and then hemostasis and apoptosis will happen. And the only remaining cells will be the surviving memory cells that keeps the its antigen recognition for a prolonged period of time. The T cell checkpoints and co-stimulatory pathways. So this is a cartoon of the tumor or antigen presenting cells on the left in the orange cell, and on the right is a T cell. The T cell have actually an interaction with the APC/tumor through multiple pathways, either on an activation pathway. So these pathways can be activated via IO agents to counteract tumor-mediated inhibition. So the tumor will inhibit the certain active pathway, so you can actually target it by an IO. And then we have the more commonly tackled pathway, which is the pathway that actually cause inhibition of the T cells. This pathways, like example CTLA4 and with its ligands CD80 and CD86, and the PD1 receptor with its ligand PDL1 and PDL2. These pathways can be blocked via IO agent to counteract tumor-mediated inhibition. In Yervoy and ipilimumab, the cytotoxic T lymphocyte antigen is a negative regulator of T cell activation. Ipi is a monoclonal antibody that binds to CTLA4 and blocks the interaction of the CTLA4 to its ligand CD80 and CD86. However, this blockade can augment T cell activation and proliferation. If you look at this cartoon on the bottom, the T cell activation here, the ligand CD80 and CD86 will interact with a stimulatory or an activation receptor, the CD28. However, if the pathway is going into inhibition, the CD80 and the CD86 will actually stimulate the CTLA4 receptor, causing inhibition of the T cells. So if you add ipilimumab, which typically blocks the CTLA4, it will stop the inhibitory activity of the CTLA4 and keeps the ligand CD80 and CD86 into its active or T cell activation channel through the CD28. So the role of PD-1 pathway mechanism of action of NIVO, of course, this is very clear. We know we have an inactive T cell. The cartoon just moves too fast. We have an inactive T cells. It's usually when it interacts with the tumor cells through the antigen recognition via MHC plus tumor antigen recognition, the TCR, it will be activated to kill the tumor cells. However, in this pathway, the PD-1 receptor, which is typically an inhibitor receptor on the T cells, will be interacted with the PD-L1 presenting on the tumor cell, and this will lead into inhibition of the T cell and sequentially the survival of the tumor cells. So immunocheckpoint inhibitors has a potential as part of a combination regimen, simply because they work at different stages of the immunocycle. So data suggests that the CTLA4 pathway, which is blocked by the ipilimumab, will most probably work in the periphery, mostly the lymph nodes, through the inhibition of the CTLA4, the inhibitory T cell receptor, via its interaction with the dendritic cells. And the PD-L1 inhibitor will act on the stopping the interaction between the PD-1 receptors at the T cells and the PD-L1 ligands on the tumor cells in the tumor microenvironment. So here simply both immunotherapy or not those, each of the immunotherapies will be targeting the channel and the pathway of the immune cycle of the tumors, of interaction of the immune system with the tumor cells at different phases of this cycle. So the safety and efficacy of ipilimumab and nivolumab, and it's through its mechanism of action. We know that ipi acts earlier in the immune response. When HCTLA4 is blocked, the response may be more or less general, and it's usually more toxic than anti-PD-1. However, nivo acts later in the immune response after the T cell is activated. When PD-1 is blocked, the response is more specific and it's usually better tolerated. So dual immunotherapy increases the chance of a superior immune response. Yervoy, the only approved CTLA4 inhibitor, impacts T cell response at the lymph node level at the priming phase. activating and proliferating cytotoxic T cells, creating memory T cells also, while Opdivo blocks a different immunocheckpoint inhibitor, the PD-1, at the tumor microenvironment. So potentially a synergistic mechanism. So another thing, when you look at the data from the ipilimumab, this is a very nice Kaplan-Meier curve or survival curve. You look about the data of ipilimumab after 10 years. So this data is collected for 10 years for a patient who used ipilimumab. When you look at the curve, initially it's just like a regular curve, just like the proportion alive or the survival is dropping. And at this specific point, we see what we call the tail of the curve. The tail of the curve, I simply say, is the part where the line simply goes almost parallel to the time interval x-axis. And this means at 3 years, overall survival rate was around 22%, with a median overall survival of 11.4%, 11.4 months. But in this manuscript, the longest follow-up of a largest number of melanoma patients treated with ipilimumab, Professor Stephen Howdy, Assistant Professor of Medicine in Dana-Farber Cancer Institute, told the Congress that our finding demonstrates that there is a plateau in overall survival, which begins around the 3rd year and extends through the 10th year. Simply saying that if your patient, just the percentage of your patients that will reach the 3rd year in survival mode will have a very, very good chance of reaching more or less the 10th year, which is very interesting to see. So this is a Checkmate 067 study design. So this study was made for a 5-year follow-up of a randomized double-blinded phase 3 study to compare Nivo plus Ipi or Nivo alone with Ipi or Ipi alone. Unresectable or metastatic melanoma, and this was a ground zero for immunotherapy studies, and this is why we chose to illustrate this studies. Randomized 1:1:1, stratified by BRAF status, M staging, tumor PD-L1 expression by more than 5% or less than 5%, more than 900 patients randomized, either Nivo 1 milligram per kg plus Ipi 3 milligram per kg every 3 weeks. The Ipi was kept for 4 doses, then Nivo will be sustained every 2 weeks beyond that. Another arm was the Nivo alone plus Ipi matched placebo, and Ipi 3 milligrams. Another arm will be Ipi 3 milligrams every 3 weeks for 4 doses plus Nivo matched placebo. When we look at the patient characteristics of this study, it included all groups of patients that we wanted. The ECOG performance status, more or less 0 were around 73%, around 70% of the arms, and around 25% was ECOG performance 1. LDH, one of the prognostic factors for melanoma, we got 36% with a high LDH. We got also around only 4% or 5% with brain metastasis at baseline. PD-L1 status, we got around 20% positive for PD-L1, and I'm talking about more than 5%, and around 67% negative. BRAF status as a mutant was around 30%, and BRAF status wild type was around 60%. So this is the survival curve. When you look, you remember it's a 3-arm study. In the top arm was the Nivo plus Ipi, followed by Nivo in the blue one, in the blue shade, and the gray one was the Ipi alone. So clearly it is an escalating survival improvement. So Ipi was the bottom, followed by Nivo, and then the combination at top has a ratio of 0.83, and this was actually in comparison to the Nivo. If you compare the hazard ratio of the combination in comparison to the Ipi alone, it will has a ratio of will be 0.52. The median overall survival was not reached for the combination, and the median overall survival for the Nivo was 36.9 months, and the Ipi was 19.9 months. When you look at the PFS, it was not a different, also an improved PFS with the combination of Nivo plus Ipi. versus Nivo versus IPI over the 5 years. We have a hazard ratio of the combination versus Nivo of 0.79, the hazard ratio of a combination versus IPI of 0.42. When you look at the median progression-free survival of the combination Nivo plus IPI, it was 11.5 months versus 6.9 months for the Nivo and 2.9 months for the IPI alone. When you look at the overall response rate, so here in the middle will be the combination of the IPI and Nivi, we got a response rate of around 58%. And we got a response rate with a Nivo alone of 44% and only a 19% with the IPI alone. This was actually interesting. So you're talking about a metastatic patient with more than 60% response rate for immunotherapy, initially recognized as something that will not really get you a very deep response. So definitely you can start getting that with the combination at the least. When you look at the complete responses, the complete eradication of the tumor, at least radiologically, you find the complete response of around 11.5% with the IPI, Nivo combination, around 8.9% with a Nivo alone, and only 2.2% with a IPI alone. Also something that was interesting in analyzing an analysis of the data here, that the increased complete responses with time. So the more you follow it, when you look at this, this is the response rate with a checkmate 67 melanoma, the Nivo plus IPI arm. You find here, when you follow it from 9 months, 36 months, and 16 months, the response rate is not really changing. So you're not going to reach more response with time, at least after 9 months. But what you can observe here, and because this blue component signifies the complete response. So actually, the partial response were gradually, in this study, increase in value. So you started by only 11% of your patient getting complete response, but by 60 months, 5 years, you will reach 22%. So this is a very interesting phenomena. That means that once you get a benefit, there is a chance of your partial response to convert to complete response with time, and this will consolidate the benefit. And I think this is part of the explanation of why the patients who crossed initially in one of the earliest slides, crossed the 3-year survival with IPI alone, for example, they started to plateau. And most probably it's because the benefit just keeps going on. When you look about the 5-year overall survival updates in the important subgroups, I'm sorry about this. This is a mutation here. This is the data from overall survival updates in the BRAF mutated. Well, we know that BRAF mutation in melanoma is a big thing with a specific array of drugs that you can use in this entity. However, when you look at this, we still have the separation of what we expected. Of the one on the top is for the combination of Nivo plus IPI. In the BRAF mutant, we have 60% versus 40% for the nivolumab arm. However, the benefit we get with the combination of the Nivo plus IPI versus the Nivo alone was actually a little bit smaller when we went into the patient without BRAF mutation. So in general, the patient with BRAF mutation will have an advantage in the use of combination. You can still use a combination without the BRAF mutation. However, with a BRAF mutation, it will be a bigger separation of the curve, of course, plus the added value of using BRAF inhibitors. Also here, we look at the 5-year overall survival update. So this is a continuation of this benefit with hazard ratio of 0.83. All this data provoked the FDA in 2016 to approve the Nivo in combination with IPI in patients with BRAF wild type and BRAF mutant positive advanced melanoma. Going into the thing that I think you will be expecting to talk about, the safety summary here. So when you look about the Nivo plus Ipi and versus Nivo and Ipi alone, we look at the treatment-related adverse events. I will emphasize on the grade 3 and 4 because this is the serious one. So we got 59% of the combination getting grade 3/4 toxicities versus only 22% for the Nivo and 27.7% for the Ipi. However, interesting, when you look at the treatment-related adverse events that leading into discontinuation, this 60% almost the chance of occurrence of grade 3 and 4 decreased into discontinuation in 30% of patients versus 8% in the Nivo and 13.5% for the Ipi. So definitely a combination of Nivo plus Ipi have its edge, its kick related to the treatment-related adverse events, and it will lead some patients to discontinue this study at least. However, this is here an interesting finding. So they actually continued in the Checkmate 067 in observing the survival in the patient treated with Nivo and Ipi and discontinued treatment due to treatment-related adverse events, not because of progression. Here, it was actually interesting because this one on the left was a progression-free survival and one on the right was overall survival. We find the blunt line here is the patient who discontinued treatment due to adverse events, and the dotted line was the patient who did not discontinue treatment due to adverse events. So we here can see that actually the patient who discontinued treatment due to treatment-related adverse event have fared actually better than the patient who didn't discontinue treatment, with a clear separation here of the curve. Also, the Checkmate 067 post-hoc analysis in the treatment-free interval for the patient who discontinued the treatment due to toxicity, we find that the median treatment-free interval for the Nivo plus Ipi was actually longer, it was around 18 months in average. So the TFI in patient who discontinued treatment from the combination versus patient who actually received subsequent systemic therapy faster, Nivo will allow you to stay free of treatment for definitely a longer time than on the side of the Nivo and Ipi alone. So what's exactly the most common immune-related adverse events for Nivo monotherapy and nivolumab in combination with ipilimumab? So here is a cartoon to show different kinds of toxicity grades and different kinds of toxicities in 3 subsets of patients. So the first arm will be the Nivo arm. This is a pooled data from more than around 3,000 patients. The the second one will be Nivo 1 milligram versus and plus Ipi 3 milligrams in the melanoma study, and we got Nivo 3 milligrams and Ipi 1 milligram in the RCC studies. So this is the illustration of the 3 subsets of patient. Clearly, the arm with the Nivo 1 milligram and Ipi 3 milligrams per kg was actually on the top with the highest tier of toxicity, and the orange one will represent the grade 3 and 4, and the one will be the total toxicities. Followed by the toxicity you can get with the Nivo 3 milligrams and the Ipi 1 milligram in the RCC combination. At the end, at the lower, it will be only the Nivo alone. So clearly, Ipi is the component that will lead to the increase in the toxicity. So when you look at the data from the RCC, where we are using a smaller dose of the Ipi and a higher dose from the Nivo, you will find that the toxicity will actually be better in comparison to the melanoma study, where we use a higher dose of the Ipi and a smaller dose of the Nivo. When you look at what studies what kind of toxicities that really stand out in this combination, most probably it was the rash and the diarrhea and colitis and endocrinopathies. Median time to onset of immune-related adverse events with Nivo plus Ipi regimen in the Checkmate 067 tends to occur earlier with the regimen of combination than with the Nivo alone. So in the The red line here will be with a nivo plus ipi, and the blue ones will be with the nivo alone. So if you look at the red ones, the initiation median will be always earlier than the time with the nivo occurrence of the toxicities. So a nivo plus ipi will lead to an earlier onset of the immune-related adverse events based on this study. So about the time of resolution of immune-mediated adverse reaction, the majority of grade 3 and 4 immune-related adverse events resolve with the exception of endocrinopathies. So when you look at this, toxicities, endocrinopathy, gastrointestinal, hepatic, pulmonary, renal, and rash, and this is Opdivo plus Yervoy in melanoma, in RCC, and the Opdivo pooled data. We'll see most of them are in the range of the 90s and 80s. Well, this means all of them have, all the toxicities have resolved in 91% example of patients, 92%, 87%, more or less of the higher chance. The least one will be, of course, the endocrinopathies, which they actually tend to persist. It's very common because the effect on the thyroid will persist, and followed a little bit by the rash. However, more than 2/3 will be resolved completely. So our general approach, this is the last slide. I know I'm the last one, so I'll try to give you a summary of how to manage to safety management for patients with immunotherapy. This is a general approach. We have a lot of guidelines and recommendations in different entities and bodies. However, this is like a general scheme for it. So first of thing, you have to, when you have a suspicious for an immune-related adverse event, or a toxicity, you have to be very careful, restricted by this one. This is a red zone. You have to know exactly what's happening. First, you have to rule out other possible causes of adverse events. So make sure it's not a non-drug cause identified. You have to manage accordingly. If it is likely a drug related, you have to start following your schemes and your guidelines for this management. If you have a mild grade, so most probably it will include a monitoring closely of it if it's a grade 1, and the immunotherapy can continue except considering maybe delay for pneumonitis. If it's a grade 2, a moderate toxicity, asymptomatic management will be in place, monitor closely. If persistent toxicity, and oral steroids can be used, hold the dose except of skin or endocrine where it can be maintained, and resume when adverse event resolved to grade 1 or less. If you have severe grade 3 or 4, you have to consult specialists, and this is an important thing to know. We have to symptomatic management, hospitalization in certain situations, and monitor closely using immunosuppressants, corticosteroids, high dose IV steroids. If not improving, we can add some other immunosuppressants, infliximab, for example. Also, discontinuation permanently, more or less, should be adapted in all severe toxicity, however, except for skin and some endocrinal toxicities. This will be all for my talk, and I thank you for listening and observing.
Thank you, Dr. Amr, for this excellent presentation, and I'd like to thank all the 90 people online watching us till the end of our lecture. Alhamdulillah.
Yes, and I will thank them with you.
Yes. I have a question, Dr. Amr.
Yes.
You presented in details the checkmate 67 or 67 in details. And then I think we have the data from the RCC trial of combo IO of reducing or changing the doses of ipi and the nivo with a better toxicity. Yes. You think we can generalize the data we have from the RCC trial for all the solid tumors when using the IO combinations?
That's really a good question, actually. But I will definitely answer, because I personally am interested in this thing, and I think we are all waiting to see how it's going to happen, what will happen on ground. What we learned so far with the immunotherapy is that it appears that we know a lot, but clearly we are not sure that all tumors will react in the same way to immunotherapies. We have seen it repeatedly in studies that we predicted that it happened with its brothers, so it will get the same benefit with another anti-PD-1 or anti-PD-L1, and it will just keeps happening again. That will it doesn't respond equivalently. And we just got a data today, we just published for a study in Royal Marsden, where we got an approval for high TMB, for example, for using pembrolizumab. MD Anderson just published a study that proved that high TMB will not predict response to checkpoint inhibitors in all type of cancer equivalently. So going back to your question, by this thing, I think we will have to be very careful about manipulating the dosing and the patterns, because it's just not about getting the right dose for the specific for the drug. It has to be the right dose for the specific indication. I think we have to stick, at least for now, for the specific dosing for the specific indication. At least that's what I see.
Okay. I don't know if we have any question from the attendees. Please send to the Q&A and we receive in the panel chat here. I think we didn't receive any question from the attendees. They are sleeping. I don't know.
Yes. Is it going out?
I have a question now.
Yeah.
No. Actually, our IT support said no questions received.
Okay.
So by this, I would like to end our day one meeting. Inshallah, I hope to see you all on day two meeting tomorrow at 6 p.m. Cairo local time, 7 p.m. Riyadh local time, 4 p.m. UTC. Also, I would like to remind you all to pray for our dear professor, Dr. Amr Lotfi. So please don't forget him in your prayer today, tomorrow, and every day. Thank you. Have a good day and see you tomorrow, inshallah. Thank you, Dr. Amr. Assalamu alaikum.